Good evening and welcome to this TVS webinar on service redesign, how a tissue viability nurse developed and improved acute wound care through real-world evidence and partnership working. My name's Jackie Hughes, I'm Clinical Excellence Manager at Smith+Nephew, and it's a real privilege to have Clare Checketts as our presenter this evening. Clare is an experienced, dynamic and innovative clinical lead in tissue viability, with a keen interest in quality improvement and is a published author. Clare will be presenting on her experiences as a tissue viability nurse and how she wanted to reduce variations in wound care practice and as a result redesigned her tissue viability service at the Shrewsbury and Telford Hospital NHS Trust. I will now hand over to Clare and the main presentation.
Hi, thanks very much, Jackie, and hi to everyone this evening. Thank you for joining us. I'm delighted to have been asked to present this evening and share with you the work that we've done within my acute trust. And I really hope you enjoy this evening, and if you have anything to ask, please do fire away. So if we go on to the next slide, please. And there's us. And the next one's just a little disclaimer just from the company Smith+Nephew. Okay, so if we go on to the first slide for me, please. Thank you. So just to give a little bit of background then really to how we've landed where we have. So as part of modernisation within the NHS, the redesign of local health services often falls to local leadership. And with this, there is an ever increasing demand for services along with higher expectations. And NHS leaders, especially in our world of tissue viability, must challenge existing systems and devise innovative solutions that deliver improvements not only for patients, but also for the wider health economy. And I believe our clinical leaders are instrumental to any change in practice. And it's not only their clinical expertise that is needed, but it's their potential influence to ensure widespread adoption of service improvement interventions. And I think we can often shy away from industry working for fear of products being thrust upon us. But equally, collaboration with industry can be really productive in terms of collecting and analysing wound care data that can inform practice change and therefore help with service redesign. Next slide, please. So as we know, the NHS continues to face significant challenges with pressure to implement quality improvement interventions. And this is at a time of increased financial and workload pressures, and especially with everything that's gone on in the last couple of years with COVID. And as a result, the NHS has historically adopted different initiatives and approaches to improve quality. And audits, we've all heard of audits, in practice are one such approach. However, while the drive to improvement continues to be a priority, implementation can often be weak, and variations in healthcare practice are recognised as a fundamental issue in healthcare performance. And for wound care services, variations in care are particularly problematic, partly because of the sheer number of dressings and treatments available to us as clinicians. And measuring what this looks like is crucial for clinical practice. And, you know, anecdotally in our areas, we often know or believe we know what should change, but how do we do this, and how do we evidence this, and how do we convince somebody else that we need to change? And that's where audits are extremely valuable, as they have the ability to measure current practice against a defined standard. Next slide, please. So in terms of the collaboration work between myself, our trust and Smith+Nephew, this was key to reaching the objective to redesign my service. So an initial plan was drawn up with all parties, and a pre-audit was carried out across acute ward settings and the emergency department. And staff were asked to document wound characteristics and the treatment associated with them. And once the data was analysed, there was an immediate opportunity to improve practice through formulary changes, which could potentially impact on variations in care. And reducing the number of foam dressings on the formulary was implemented, and the leave-in family of dressings was made available to staff. So with this, a bespoke education plan was put in place with the Smith+Nephew team, and they were delivering this training at Tissue Viability Link Nurse training for dissemination to their clinical areas. And training was given on how to use the pathways and how to also make appropriate dressing selections. But a repeat survey was also carried out to directly compare the results of this intervention with the data collected before its implementation. And to ensure the results were not influenced by COVID, our data was collected from 2 pre-pandemic periods of 6 months. So that was October 2018 to March 2019, and again in October 2019 to March 2020. And from this, as you can see on the screen, 2 clinical pathways were developed and distributed to the ward and emergency areas, which covered X-shape management and skin tears. And I am a big believer in not reinventing the wheel. So the pathways you see will be similar to other pathways that we've adapted with permission from other trusts, because I think it's really important that we share good practice and not work in silos. And as I said, there's no point reinventing the wheel if someone else has done it. So let's adapt that and make it relevant for our trust. Next slide, please. So numbers, not my strongest subject, but for those of you who are interested in numbers, this is the slide for you. So analysis of the types of wound dressings used pre and post interventions demonstrated that the proportion of foam dressings used increased significantly in the post-intervention period. And that was from 41.3% to 61.8%. But that was also offset due to an equal decrease in the number of other dressings used. So it was expected that other usage would continue until ward stocks ran down of alternative foam dressings. But also if we think of our kind of dressing sandwiches as well, and I'm sure we've all seen some very interesting combinations out there, but also that reduced because of that removal of an unwanted variation. In order to gain a practical overview of the wound care service, my team carried out the majority of dressing changes, which were 98%. In the post-intervention period, this reduced down to 72.3% of all dressings being undertaken by ward staff. And this is huge, and this shows how valuable education and support is for staff to undertake dressing changes, but not just undertake the dressing changes, to undertake them with confidence. And it's really interesting that, you know, I say our team, there's myself and one other person who is fantastic, and we work together brilliantly, but we can't be everything to everybody. So we were doing all these dressing changes because of that lack of education that was out there, but we were inadvertently disempowering our ward nurses, and you become stuck in this vicious cycle where you know there's education that's needed, but you don't have the capacity to deliver that education. Therefore, you do the job that needs doing, which then disempowers the nurses. So if we think of all our sort of specialisms, you know, our sort of, you know, people won't get people out of bed until they have a physio review. We're kind of denying our nursing teams of using their own clinical judgment and standing on their own 2 feet. And the post-audit results of this really demonstrate how key that is when we're implementing any change, that we are providing that education to allow our nurses to nurse, to do what they're supposed to do. Next slide, please. So just to talk a little bit here, so wounds that were dressed in the post-intervention period had lower exudate levels than in the pre-survey. Now, I believe this change could be attributed to the education provided, but of course it could also be viewed as simply a change in assessing clinician. We know that it is well documented that inappropriate dressing selection may increase the risk of complications and impede healing. So therefore, in addition to time training, the clinical pathways were designed to give the clinicians at ward level not only the confidence to select the correct dressing, but also encouraging them to change the dressing when absolutely necessary. And the post-intervention period showed lower frequencies of dressing changes than the pre-intervention period, with only 29.8% of wean dressings being changed more than twice per week, down from the 56.3% before the intervention. And also, in addition, the mean number of dressing changes reduced from 3.01 to 2.36 per week. So again, as I said before, it really demonstrates that sometimes it's not that the dressing is changing, it's the lack of awareness and that lack of education and understanding of the mechanisms of the dressing and the absorbency properties within that dressing. And being able to do this demonstrated how simple and easy it was for our nursing teams to understand that, but also for our patients to understand that. Because we've all had patients where a tiny little bit of strike through on their dressing and they straight away believe that needs to be changed. And that can actually be really costly. So it's so fundamental and so valuable that alongside these changes that we are making, that we demonstrate the impact of these, and that's through our education and support. Next slide, please. So given the differences in exudate levels between the two periods, it was important to perform a secondary analysis to assess the frequency of dressing changes across exudate levels. So although none of the subsets had enough data to achieve statistical significance, so that's our p-values being less than 0.01, at all levels with actual exudate, a lower mean number of dressing changes was observed. Next slide, please. So analysis of the support and financial data showed that the total spend on foam dressings during the 6-month pre-intervention period was just over £42,000. In the post-intervention period, the figure had reduced to just over £28,000, and that was a 33% reduction. So you can imagine procurement were very, very happy about this. And interestingly, the mean monthly reduction on spending on foam dressings reduced from just over £7,000 to just over £4,500, which was statistically significant, as you can see. And that's in the pre and post intervention periods, respectively. Next slide, please. I've realised I've raced through this. So the mean, just to kind of go through everything we've done. So the mean monthly reduction in spending on foam dressings reduced from just over £7,000 to just over £4,500. And that was with statistical significance. The standardisation of wound care through the use of clinical pathways alongside education programmes can help to reduce variations in care. And the mean number of dressing changes reduced from 3.01 to 2.36 per week. And by switching to leave-in wound dressings as our sole formulary listing for foam dressings, our trust has experienced a reduction in the overall volume of dressings used. And the overall volume of the dressings used by our service in the pre and post-intervention periods decreased from £22,965 to £21,865. So that was a 4.8% reduction. And the post-intervention period showed lower frequencies of dressing changes than the pre-intervention period. So that was with only 29.8% of wound dressings being changed more than twice per week, down from the 56.3% before the intervention. So just to kind of summarise everything as a whole, really, I suppose my message to you is to optimise quality and efficiency. A framework that considers governance, quality and efficiency equally is needed. And leaders, us as leaders of our NHS services, need to constantly challenge the status quo and tackle constraints related to out-of-date payment systems, which ultimately prevent the freedom to innovate. And by switching to the leave-in family of dressings in SAP, we were able to reduce the number of dressings being used, which then translates into less waste and a reduction in variations in care. And if we just think of less waste in terms of our economy, in terms of, plastic wastage, so it goes much further than just within our local trust. And the results of that can be phenomenal. And also it shows how wound care audits can inform and change clinical practice for the benefits of both patients and for the wider health economy. And, this is where I speak about if we're going to audit something, it's so important that we're doing it for a purpose. We're doing it for a reason. We're doing it because we want to make a change and we want to implement a change and sustain that change. So, which is really, really, really important why we did the post audit, because often, and those of us who experience change in practice, it can be really difficult to get everybody on board with you and to go through that journey with you. So sometimes we need to actually demonstrate the impact of that. And hopefully from what the short snippet of what you can see here today, we have demonstrated just what can be achieved, and it wasn't difficult to do either. But also, this whole process, it allows NHS leadership to develop skills in data analysis, planning of a service and service redesign. And the experience of our trust demonstrates the positive impact that adopting a standardised approach to wound dressing selection can have, and particularly in terms of reducing variations in care. So, it doesn't sound a lot, but these innovative ways of working, combined with openness to work collaboratively with the wound care industry, it's about finding solutions, and it is key to meeting the efficiency challenges facing the NHS. And, we all know, we've all heard of the guest paper and the cost of wound care and the cost of wound complications and everything else that's associated with it. And we're the people that can make that change, and we're the people that can implement positive solutions that meet the cost targets, that meet those key performance indicators for quality, but also with the patients at the forefront of everything we do. And as I say, I hope if you take away anything, you take away that no matter how big or small your teams are, you can work collaboratively with industry. We don't need to be afraid of industry. We don't need to shy away and be concerned about whether products are being instilled upon us. We can use them as our resource when we haven't got the resources within our own teams or our own capacities. And we can work together to achieve really, really great results, and more so than I anticipated at the start of, I hate the word journey, but the start of our journey with Smith+Nephew to developing this sort of way of working, and the difference it has made within my trust, within our service. And, to hear other people who are wanting to learn from that, it's amazing, it's incredible to do. And like anything in our world of kind of tissue viability, we're often, navigating through and learning from each other. And that's why I was so happy to have been asked to present to you today, because I don't want to work in my own little silo. I want to share what we've done, and I want others to adapt what we've done, or learn or change things or have ideas for their trust, because we are pinnacle in all of this. We are fundamental in leading these changes, and it's possible. As I said, our team, there's me and my colleague who's incredible, and doing this small project, it doesn't seem very big to me, but the impact it has had is allowed us time to do other things that you have to do as part of running a tissue viability service. My colleague, for example, has an incredible passion for teaching and sharing her her work and her experience with other people. And this has allowed her to go and do that and improve wound care throughout the trust. So it's not just this tiny little thing, it's about the bigger picture, and it's about what we can change, and I'm not talking about changing the world, but why not? Let's do it, and let's do it together. I'm hopefully haven't rushed through that too much. I think I started, because you never know timings, but I'll hand back over now. Thank you for listening. I really hope you've enjoyed it, and I look forward to hopefully any questions that you may have. Thank you.
Thank you, Claire. Really, really interesting. And now it's actually time for our live Q&A, and we'd love to hear from all of you that joined us today. So please pop any questions you have in the chat, and we'll try to answer as many of the submitted questions as possible. If there will be any outstanding questions after we finish today, please use our contact form, which have been linked in the chat, and we will make sure that our team support you in getting them answered afterwards. The first question, Claire, is for you, and that is, did you redesign the service or make any changes to service delivery alongside the wound care practice change?
So the first part of that, did
you redesign the service or make changes to service delivery alongside wound care practice change?
I think so, yeah. I think it all went very much, hand in hand. So what I'm interpreting from that question is, alongside what we've done here,
yes,
have we redesigned other elements of our service? And I would say yes, because as I sort of briefly alluded to, this has given us time as clinicians back to focus on other areas of our service. And we are by no means perfect. There's a long way to go, but actually, as I said before, it's something so simple, so well executed, that we've got confidence in our nursing staff. So that has allowed us time to focus on educational packages, policies, guidelines, resources. So it's allowed us to kind of almost change the way we work, and not so much do because of worries of what's going on out there, but we've got more confidence, and the nursing teams have more confidence in what they do. So we found that, for example, something like referrals into our service, if a patient is referred to us, and we're looking at what's been done so far, what's been done is appropriate, and they've got the appropriate dressing in place. So we have to do a bit less than what we did before for that person. So I would say yes, we've still got, we've got so many ideas of what we'd like to do, but it has helped us tremendously in redesigning other aspects of our service. So I hope that answers your question there. Thank you.
Another question is, Claire, how did you even start with the idea of redesigning your service? It sounds daunting.
Oh yes, daunting. It was really daunting, the prospect of it to begin with. My background, so I've been in this role for coming up around 3 years now, and my background was kind of acute medicine, respiratory medicine, so experience within tissue viability, but I didn't come from being a tissue viability nurse or a district nurse or an experienced wound care nurse. So, and the world of tissue viability can be very sort of daunting and difficult to navigate and know who to trust, who is only interested in bringing you products, who's got the patient's best interests at heart. And it is that, but what I would say is, with starting with the process of redesign, it's about starting on one particular area. Don't try and take everything on board at once. I think we've all been guilty of that. We can't change the world in a day. But I started in what I felt to be a big enough area. Like, I sort of, anecdotally knew there was something not right with dressing selection, with wound care practice in the trust, but I didn't know where to start. I didn't know where to begin. And, as new to the post, you can imagine industry partners kind of came at me like a moth to a flame. But I was able to work, and that's, it's easy to work with Smith+Nephew in that respect, because I knew that it was about patient quality, cost effectiveness, but also that level of support that they were offering me took the burden from my shoulders. So I felt that I could start with this area. They supported me all the way with that. So as we went along, it was less daunting. And then other areas of your service then become easier to achieve, because you've got a bit more experience behind you of how to kind of navigate through. So yes, I would say daunting, but just start with what you see an issue with. Don't try and tackle everything at once. There's something, historic things that I'm still tackling now that have been, 20 years old in the trust, but it's about doing what you can within your gift, within your power, and using the resources around you. And actually, tissue viability, you may feel that you've got a very small team, but even just our regional colleagues have been a great support to use them, and use our industry partners, because they come with a wealth of experience as well, and a great resource for advice. Thank you. I hope that answers that one. I do go on a bit on a tangent, but
yeah, that's great. Our next question is, did you get any resistance from surgeons or procurement when switching your foam products? If you did, how did you overcome the pushback?
Resistance from procurement? No, unheard of. So initially, yes, probably a little bit of resistance, because I do actually have a great level of respect for our procurement colleagues, because it is their job to think about cost. And as I sort of briefly alluded to, the NHS, it is a business, so we do have to think of what's cost effective, but also what delivers quality. And certainly, as a TVN, you can become very kind of tunnel visioned of, I like this, I want this on my formulary, I don't care what it costs. But actually, it's about working with them. So it's not going in all guns blazing, this is what I want, this is what I'm getting. And that's exactly why we did the audit, because I knew what the issues were, but this non-clinician doesn't know what the issues are. And how am I going to persuade them to my line of thinking? So that's why we did the audit, to show the problem, to demonstrate the problem, and equally why we did a post audit, so we can kind of go, this is the results of what we've done. And if it was found that quality had decreased and costs had increased, then okay, we need to revisit that. But having that evidence that and it's talking the language sometimes of procurement, if we can evidence the kind of long-term costs, and sometimes procurement can be very kind of short-term solutions, whereas as tissue viability experts, as district nurses, as anyone involved in wound care, we all know of the the insidious costs that come with, for example, if you carry on using this cheaper dressing, you're using it but having to change it every day, as opposed to this one that you can keep on for a week. So actually it's cheaper if you go with this one, but because the initial cost is more expensive, and it becomes a little bit of a battle of sorts sometimes. But I would say, if don't go in open, listen to procurement, listen to, I didn't have any resistance of surgeons, actually, surprisingly, but just listen, and don't listen to respond, listen to hear them, hear what their problems are, let them again listen to you to hear what your issues, and reach that compromise, but be prepared to evidence anything that you want to change. Show them the issues and then work together on resolving them.
Claire, could I just pop in there as well? When you talk about sort of procurement colleagues, how did you find your internal clinical colleagues? So those nurses that perhaps you had to maybe convince this was a good idea to do, it's quite a big project. Did you have any resistance there? Did you have to bring any sort of groups with you, or was it accepted quite readily, really?
I would say it was probably actually accepted really well. And I think that is because there was so much uncertainty. You know, we had, I know, 2 or 3 different foam dressings on our formulary. Nobody really understood any one of them. Some were, you know, might have had different properties and they weren't necessarily appropriate for a wound. And there was a lot of kind of confusion, I'd say. Or, you know, certainly people felt they were doing the right thing, but just didn't have that understanding of actually, you know, that's probably not the best one. Oh, but what do you mean? It looks like any other foam dressing, you know. So I would say, I think it went quite smooth, surprisingly quite smoothly, actually. I think, you know, I certainly don't recall any resistance from our nursing teams. I think, you know, it helps. It's the company most people have heard of. You know, it's a trusted company. I think because of the level of support and education that went with it alongside the pathways really helped. We didn't just, and we've all been there where someone's just changed something in your shelves and then runs off and hides and just lets it all unfold. We were very clear that we wanted to educate people. So it was a gradual process and we involved people and listened to people as well. So I think that's why it went smoothly, because it wasn't just, here's your new dressing, see you later, good night, Vienna. It was, here's your new dressing, this is how we're going to use it, these are the pathways, talk to us, what do you think? And we've had really great feedback from patients and staff alike. Does that answer that, Jackie? Sorry.
It does, thank you. Yeah.
I actually think next question is directed to you, Jackie. So when working with industry, how can we be sure that patient confidentiality is maintained around the handling of data?
Okay, Louise, really good question. I think for any clinician really, and obviously I'm a clinician myself, but working in industry, I think it's really important to understand from that industry partner how they actually manage your data. From a Smith+Nephew point of view, we don't collect any patient identifiable data at all. So we just collect information around prevalence, who's done the dressing today, a little bit about exudate management, infection, some real top line markers for wound care practice. Obviously then, what kind of software does the industry partner use? Is that confidential? Does that adhere to transparency guidelines and everything that it needs to in terms of confidentiality? And then what happens to the data afterwards? So that data should belong to Shrewsbury and Telford Hospital Trust. It's Clare's data, it's the Tissue Viability Service data, and as such then that data, any paper trail of data should be disposed of in the correct way. So I just say, if you're working with an industry partner, really check the credentials. What do they do with the data? Ask to see their policies and procedures, and that will cover you from a patient confidentiality point of view.
Thank you, Jackie. I have 2 questions quite similar. So one is, how is this working in practice months later? And the other one is, have you re-audited to see if the positive impact is sustained?
So what was the first part of that? Sorry, Louise.
How is this working in practice months later? So I think they're very similar. Have you seen the positive impact sustained?
Yeah. So the months later, I would say, I think the pathways, it's really lovely to see them being used. It's really encouraging if we read a referral that says, you know, I have followed the skin tear pathway, or I have done this before I've referred to you, but I'm referring because of other reasons. So it's really encouraging to see that actually it is still in use. And it seems to be, I mean, it's quite a while now, it seems to really have been sustained. I think so. We did the initial post audit at the time, and I think annually in the first year it was, Jackie, forgive me if I'm wrong, but it was around a £25,000 cost saving in that first year, with just under 2,000 lesser dressings being used. So huge impact. We would love to revisit, I think, down the line. A small little thing called COVID happened, so it's kind of thrown everybody's plans. But throughout that period, I would say it's still been used, and we are seeing it used, the dressing being used appropriately. And also alongside just general wound assessments and how long these dressings are being left in place, we're finding that is really beneficial. But also just to note, even tomorrow, I've got somebody from the company bringing more leave-in resources and packs to me to disseminate to our link workers. So even though all this happened, it feels like a lifetime ago now, that support has never wavered. That's always still been there. And I think that's a really strong indicator of when working with industry goes well, when you've still got their support to help you sustain and those continued changes. Does that answer that okay, Louise?
Absolutely, thank you, Claire. The next question is, do the service also support private social care providers?
Does our service support private? I don't know. In what respect? Just is there any sort of elaboration on that?
No, sorry.
Because we are. I don't know who asked the question, but if you could add a bit more just to help me understand that, because obviously we're sort of public domain. I would say in terms of we're trying or in the process of working, so we're an acute team of working with our community colleagues to try and work jointly and share our pathways across the patch. And also, we kind of work with our regional colleagues in that respect as well. In terms of private social care, though, I'm not really sure, because we're a kind of NHS provider. I don't know whether I just misinterpreted that question.
No, I think they clarified, so they meant just what you just answered, I think, working with them.
Yeah, so we don't directly work with private social care providers, just because I think with the NHS, but it doesn't exclude if anyone, the kind of thing that we've done here, I'd be happy to share with anybody who wants to make positive changes in their areas. So private, public, wouldn't matter to me. Hope that somehow helps. Whoever asked that, sorry.
I'm sure. The next question is, have you published on your work? And if so, can we please provide the references?
Yes, we have. We have published. It went, I think, back in May in the British Journal of Healthcare Management, and I'll leave Jackie to sort of share, or somebody hopefully to share the references for that, which is a bit,
to share the reference either in the chat if that's possible, or in the follow-up with for all attendees. So we'll make sure that will be shared with everyone.
Thank you.
Can I just ask Claire as well, just one last thing, how easily do you think this could be replicated in another acute trust? I know you said it was you found it quite an easy process, something to really engage with. Do you think there's kind of touch points that are common across the majority of trusts? Do you know what I'm trying to say?
Yeah, I think so. So yeah, I would say, I can't see why it wouldn't or couldn't be adapted anywhere in any, even acute or community care provider. The the actual audit process wasn't difficult to do. Initially I was worried, is this going to set me back in practice? Is this going to slow me down? We, as with any of us, a lot of the time we are firefighting or feel that we're very much firefighting. But doing the audit was just on the back of seeing a patient and just completing a few questions. It wasn't difficult to do. And then the implementation with the level of support that we received, again, was really smooth sailing, really easy to manage. And then just that post-audit period as well was, again, you know, because all the data was kind of analysed by the, you know, with help from the company, who then, you know, sent it to you in a beautiful kind of lovely booklet for you to digest and share and ask questions. So I would say, and because it was, I mean, it is just easy. It's not a difficult thing I think we've achieved in our trust. And I think anybody looking to improve something, whether it's, you know, looking at the foam dressings on your formulary or any dressing on your formulary, that pre and post audit process, I think, is really easy. And, you know, you've then got the solid, hard evidence to implement those positive changes that you want to do, and look at how those changes have therefore have then impacted upon what you do. And I think, you know, it doesn't even have to be restricted to acute. I think, you know, why couldn't this be done in a nursing home, or, you know, in a DN base, or anywhere really? So I'd encourage it anywhere, everywhere.
Yeah, so that
all
audit
across
is
the
really
world.
key. Yeah, absolutely. And I guess, because you talk about the audit process being quite easy, you know, for someone who's perhaps listening today and thinking, I'd love to do an audit, but is it going to take a lot of time? Is it, you know, is it going to be a lot of time for clinicians in the field, perhaps, if they're leads of service? Can you just kind of talk us through, you know, how much time was actually needed, I guess, to complete the audits themselves?
Yeah, so I would say it can be as little or long as you want it to be, really. You want to, I mean, we did 6 months either side, but that was within that 6 months, it was really flexible. So there was some, you know, there was a couple of weeks where I didn't, you know, might not have had time to do any of the audits, but it didn't matter, you know, as long as you get kind of the same ballpark figure of patients that you're auditing, you're in control of, you know, how much time, little or how much time you spend on it. I would say that you need to obviously have a decent enough amount of patients to make it kind of effective and see those changes, and also about how well those changes could then be generalized to other areas. You know, so if you're only perhaps doing 2 or 3 patients, it's not really going to really tell you much of what's going on. And the whole kind of point, you know, it was a snapshot audit, so it's kind of a snap of that moment in time of what's going on in your areas, and then what's going on following the change that you've made. So I would say for me, I felt completely flexible. I felt no pressure, no time frames. You know, we all know priorities can very much change in our field of tissue viability. So I was able to kind of go, well, actually, I've not got much time for that, or I can get a bit more done this week. So I found the process really flexible. I think, you know, decent enough I say I use sample size, but you know, patient size, patient group. And, you know, just be flexible, do what you can with, you know, we did it with 2 whole-time equivalents and no admin support, and we managed it, and it wasn't difficult to do. So, you know, I mean, I know there's teams even smaller than our teams, but for your bigger teams, it's achievable. But do it on your own kind of merit, do it within your own flexibility of your own work constraints. Don't be, I would say, it's not intimidating, it's not, you know, time dependent. And I think that the company were really supportive in helping with those steps along the way. So yeah, hopefully I've waffled again, but hopefully
no, it's fine, it's absolutely fine. And sometimes clinicians that do these types of audits will often look at the type of person that's dressing the wound, and I know there's been publicity around healthcare support workers in some areas get involved in wound care. Is that something you'll be looking at in the future? Is that of interest to you? Do you think that is something, you know, that could be redesigned as part of your service?
Absolutely think so. I think for us, for me, you know, I've always said we have got the resources. There are nursing teams that are out there on the shop floor, you know, or in your nursing homes, residential homes, in, you know, in your kind of care district nurses visiting patients' homes. You know, we've got the resources there. It's how we empower. And I did kind of briefly said before about how we seem to have a specialist role for most things. You know, we've got physio, we've got, you know, diabetic nurses, we've got people to assess your swallow. And although it's great, and there's definitely a need for these people, you know, and I certainly want to keep my job, so I hope they don't get rid of tissue viability nurses. But equally, it kind of, people then become, I think we develop this culture where people are fearful to use their own clinical judgment, and instead they pick up the phone and refer to tissue viability and then kind of rest on their laurels a little bit. And I think you know, things like this empowers them to do, to be a nurse, to do what they should do. But also, I'm a big, you know, I've always said a lot of nursing, a lot of what we do is very practical tasks sometimes. And, you know, changing a dressing, does that need to be a qualified member of staff to change a dressing? And I'm not saying, you know, we need to do our assessments and certainly not put an untrained staff on our complex wounds. But if we think of our simple, you know, maybe changing some bandages on a leg, or, you know, changing an Allevion on a skin tear, what are we afraid of? Why can't we allow our, you know, wider group of incredible healthcares, NAs, you know, why can't we allow them to, with understanding and with support and with guidance, empower them, let people nurse again? You know, I don't want to be old fashioned, but, you know, to a degree, let's go back a little bit and allow our teams to use their own judgment again. So absolutely.
Brilliant, thank you.
I think I have the last question for you, Claire, and that is, do you have any other plans for other aspects of wound care in your service?
Do I what, sorry, Louise?
Do you have any other plans for other aspects of wound care in your service? I think with the results in mind, if you have any other plans for other aspects of wound care in your trust.
Everything. I think as I say, I think we've, you know, there's a lot that we want to do. There's a lot that we want to improve upon within the trust. There's a lot of practices that we want to respectively challenge and equip people with the knowledge to drive changes in their areas. I think this is one area that I feel that we can kind of tick off now. I think it's been done well. I think the changes have been sustained incredibly well. Everyone's got on board with that change as well. So, you know, I think there's other aspects, you know, within maternity, you know, we're looking at sort of their areas of change within the kind of wound care delivery there, orthopedic areas. We're just kind of starting one area at a time. But what I'm really keen to do is, and, you know, I want, as I say, our team, it's tiny, but we really want to continue with this great kind of improvement work. And, you know, I mean, it's no secret our trust gets quite a lot of bad press. We want to really be pioneers of wound care within our trust, and I don't think that's hard to achieve. I think most people who work in tissue viability know just historically it's quite a poorly invested in service, and we can sometimes be at a bit of a poor relation, and that can feel quite demoralizing at times. But I would say, you know, it's, if you've got it within, if you've got that passion, and as I say, my colleague Leanne is incredibly passionate about what she does. You know, we're both on the same page. We've achieved this, and it's, you know, it's been published. That's huge. You know, as I say, for us, it just felt like, oh, we've just changed a dressing. You know, we haven't done anything amazing. But actually, do you know what we have? And the impact on our patients and our nursing teams that it has been phenomenal. So why just stop there? You know, I do think in tissue viability, the world is your oyster. And oh goodness, yeah, we want to do everything and anything we can to, you know, really be leaders really in the tissue viability world. And I don't think it's bad to be ambitious. You know, so aim high, why not?
Totally agree. And I want to say thank you so much, Claire, for sharing your story and your great project with us tonight. I had a terrific time listening to you, and I hope all of you attending did the same. And if we, for some reason, missed your question or didn't respond to it, please feel free to reach out to through the contact form in the chat, and we will make sure to support you further. But also, if you have any additional questions and what we've done with Claire, reach out and we will make sure that we can talk about how we can support you in a similar way. As I said, I want to say special thanks to you, Claire, for sharing your amazing work, and to you, Jackie, also, and for TVS arranging. And there will be a recorded version available shortly after on TVS website, so you can go back and share with your colleagues if there's anyone that weren't able to attend this evening. And with that, I want to wish you all a great rest of the evening. Thank you so much for joining.
Thank you, Claire. Thanks, Louise.
Thank you.
Thank you.